I'm gonna, here we go. So, morning, everybody. My name's McCord, and some of you will know me and others may not. So, I'm a pharmacist in the Southern Trust, and my speciality is ILD. So it is. I have a few slides here today to show and share, and I'm going to do share screen. So hopefully it works. So we'll put it as a slideshow, and then share.
Here's Sylvia. Yeah, I'm coming now.
Let's see.
Right. I got nothing of that. No, and I go up to the show me. Oh, chart. Where you from? Okay. I think that way. So the roads are tricky. I'm sure the country roads. Well, how are we?
All right, I'm trying to get out of this now.
Oh.
Can everybody see that yet, or how are we going?
Yep.
Yes.
Yes, you can see it. And you're not seeing like an inbox of emails or something like that. Always possible with me too. So, morning, everybody. So,
Good morning.
Today I'm going to cover pharmacological considerations in ILD. And basically what I'm going to do is try and follow on from the very excellent talk that Mariam Nakvi gave just in December. Wee bit about myself. So as I said, I am a pharmacist. I qualified in 2008, registered in 2009, and all of my career to date has been in hospital pharmacy. So I'm very much a hospital pharmacist. Came to ILD in February 2021, and that really was a move away from cancer services and the clinical role. And it was after I just completed my master's as well. So those were things that were happening behind the scenes, and with one thing and another, a post came up and it was an ILD, and I thought, I don't know much about this, but I was interested, and it has been a very, very rewarding role that I really do enjoy. So just moving on to the next slide, I'm wondering if this is going to flow. So a wee bit about myself then. I work part-time. I am a mum of 3. I like getting out and about. We also have a dog. She's called Bonnie. And my little girl is obsessed with a thing called Joke of the Day. So from my perspective, my joke of the day today is, what farmer's most likely to become a chemist? Anybody going to give me a clue or know the answer? Can you see the slide? So did everybody hear that?
No.
So anybody? So which farmer is most likely to become a chemist?
Is there a female? No.
Pharmacy.
Yes. Pharmacy. Well done. Yeah, well done, Desi. You got it. So pharmacy. Or farmer. Or pharmacy. Pharmacy. There we go. Oh, I'm going the wrong way. So aims of objectives. So I wanted to provide an overview of the support medication used in ILD. We wanted to look at the disease modifying medications very briefly, because they were in the majority, they were covered by Mariam. So they were cough and or breathlessness, mucus, sputum, exacerbations, where we sit with antibiotics and steroids, inhalers, vaccines, supplements, managing your medication, the future, and clinical trials. Those are the things I want to touch on. Has anybody anything they specifically thought I'd love to, know about today, or that brought them on, that they would like to have discussed? If anybody does, give me a wee. No? Everybody happy with that?
Mhm. Yeah.
So what I wanted to touch on briefly is this hierarchy of scientific evidence. So basically, when we talk about evidence and when we talk about research and so on, it's good to think, well, what does that mean? And this kind of feeds on to where I go next with it. So ideas and opinions are probably what we class as the weakest source of evidence, but one that people can put an awful lot of emphasis on. That it worked for me, or why don't you try? Those are things that we tend to put a lot of emphasis on as people. And they can be good, and they can form those ideas and opinions that can actually then lead to increased research and increased evidence and increased proof. So they are a good thing, and they can help lead, but sometimes with ideas and opinions, they're not always correct too. Okay. You can then build up all the way to your randomized control trials and up to your meta-analysis and stuff where we know there's a lot of research and we've been able to actually prove that something works. Okay. So our disease modifying medications in pulmonary fibrosis, they're broadly broken into two separate areas. There's antifibrotics, of which we only have two. There's nintedanib, OVEF, and there's pirfenidone. Nintedanib is expected to come off patent this year. So we expect to see a move from seeing it as OVEF to a brand, most likely a branded generic. That is what we're expecting. These are the two medications that we have that are licensed in varying ways for pulmonary fibrosis, be it for progressive pulmonary fibrosis or be it for idiopathic pulmonary fibrosis. We then have immunosuppressants, which we don't generally use in idiopathic pulmonary fibrosis, but you would see used more in things like rheumatology. And you will see things like prednisolone, mycophenolate, methotrexate, azathioprine, and biologics such as rituximab. And this is where I'm going to say, look, if this is what you're really interested in today, I think that if you watch back the recording that Mariam Nakfi provided on the 13th of December, it is excellent. And I didn't want to provide a duplicate talk today that went through all that again. I sort of wanted to build on it. Okay. So antifibrotics are the only ones that are licensed that we know can change the trajectory or influence the trajectory of pulmonary fibrosis. They can, and they are licensed. Immunosuppressants are generally licensed, but not specifically for pulmonary fibrosis. Okay. The other things then we're moving on to is more symptoms. I would say that most people, one of the things that leads them into coming or presenting to the GP because of pulmonary fibrosis, it's usually going to be something along the lines of cough, shortness of breath. Cough is largely one of the things that we find people are obviously trying to or want to improve. Okay. And cough, if you look at other resources, pulmonary fibrosis or Action for Pulmonary Fibrosis would break it down into, we have an acute cough, subacute cough. So an acute cough is one that lasts less than 3 weeks, usually something to do with a lower respiratory tract infection, something short term. Subacute is whenever it lasts for 3 to 8 weeks. It's these slightly longer, but our pulmonary fibrosis coughs are kind of into more these chronic cough, a persistent cough which lasts for more than 8 weeks, where a chronic cough is a very common symptom with a long-term respiratory condition, and a refractory cough, and this is a cough which persists despite ongoing treatment. And with pulmonary fibrosis, a cough can be dry, it can be tickly, and sometimes it can be productive of mucus. And sometimes it can also be a bit of a combination, or with time and flare-ups and infections and things, you can find that it sort of waxes and wanes, going from being more dry in nature, day-to-day basis, and then maybe hit with a spell with mucus. So it's these kind of, and these are the coughs that generally most, they're the most, your chronic cough, this refractory cough is your more problematic one. It's long term and it does appear in pulmonary fibrosis. Okay. Dry, unproductive cough, it can be, this is like a cough hypersensitivity, and it can be triggered by things like changes in room temperature, smoky dust, going into a different area, or triggered by talking, laughing, exercise, or exercise. And then a productive cough is one which moves phlegm from the airways, and it's our body's way of protecting the airways to try and get mucus sort of out. So looking at this, I suppose, pulmonary fibrosis cough treatment, where we currently have no approved or licensed treatments for pulmonary fibrosis cough. So unlike nintedanib and pirfenidone, we don't have some, that we know works and is licensed. We don't have one good, sort of, this is what we use and this is what we know works well. Treatable factors, so things like reflux. So things like reflux, it's thought that if you have reflux or heartburn, it's best to ensure that it's treated and treated effectively. There is a TPAL trial that has been underway that looks at whether medications such as lansoprazole can help with pulmonary fibrosis, because there is a theory out there that there is an element of acid coming up from the stomach and then going down into the lungs, and it causing irritation and possibly either worsening or exacerbating both cough and the pulmonary fibrosis. Talks about GI motility agents. These are not something that we tend to use much. And then inhaled steroids. This is again less used and more to do with blood results, where it would say eosinophils are up and there's like an asthma or a bit of a combined thing going on. Ones that we tend to see most for cough that we're using is Oromorph and codeine phosphate. Gabapentin is there. It's not something I've seen particularly, or even at all, at all in day to day. I don't know if any of you have. And one of the risk factors, which I'll talk about later, is trying to use morphine, which we have more, it has more evidence, and it wouldn't be recommended to use it with gabapentin for the majority of people. Okay. Cough, breathlessness. So quite often you'll find that codeine linctus might be tried. It is well documented as an antitussive for a non-productive dry cough. Usually it's about 5 to 10 mils 3 to 4 times a day for adults. There is a small percentage of the population who are classed as ultra-rapid metabolizers, and these people will convert codeine to morphine actually very rapidly. Okay. And then there's some patients who will be deficient in an enzyme, and for them, codeine is completely ineffective. Okay. So whenever somebody said, and I looked at the stats over the last few days, whenever I was looking at this, and depending on ethnic origin, it can actually impact on whether you're more or less likely to have these enzymes, and how. So I think it sits for the Caucasian population at about 1 to 3%. So relatively small numbers, but if you have 100 patients, you might have 1 or 2 that are not, using, or codeine won't work for either, or it will work for too fast. Side effects can include constipation. The one that you see written is respiratory depression. This is where we're using, where we do have to be careful. Using it too much is, comes with its own risk, and it's the one that we find people ask for. But we also know that there's a theory again that whenever you use codeine linctus, it is slowing down that respiratory rate a little bit, because people tend to be breathing, quite fast if it's for, breathlessness. And then the other question that people tend to ask me about is withdrawal or addiction. Okay. Probably one of the things I would say is every once in a while I get somebody and I say, well, how much of this codeine have you been taking? And they say, I'm not really sure, because I just lift the bottle and take a swig. Okay. And And that's where you tend to run into difficulty, because I don't know about you, but eyeballing and trying to make sure whether you're taking 5 mils, 10 mils, and it's where the amount that you take. And the other thing is, whenever people are reaching for it, whenever they don't need it or they're using it for other things, like, so they get into a habit of saying, well, it helps me sleep, sleep, so I take it even if I didn't have a cough, I take it at night. It's best stopped slowly or titrated down, and what we would recommend is the lowest effective dose. So if you find using it once or twice a day worked, well for you, or you find that you used it for going into sort of like, some people, if they're going to church or so on and they want to use it beforehand, they do. So lowest effective dose that works for you. And then if you find that it's not effective, then feeding it back to whoever's prescribed it. The other thing is then 15 milligrams of codeine is actually equivalent to approximately 1.5 milligrams of morphine. Okay, so the two are related. And sometimes we will have people and they will say, well, I don't want to take, I don't want to use morphine, but they're actually maybe more comfortable with codeine being prescribed. And actually, when you look at it, the dose of morphine that we generally prescribe 1 to 2, is pretty much a match in equivalence to the codeine. Okay. So with regard to Oromorph, it's the other one that we would tend to use. We don't tend to use both together. So if you were not, if you were on codeine and you were switching to morphine, we would be then discontinuing the codeine and then starting morphine. Okay. Usually you'll see use a 10 milligram and 5 ml solution. It is again an off-label use. So it's not, if you look it up and you find it's licensed for pain, but it's known to be effective for cough. Less evidence, well, I've mixed feelings about this. There's less evidence regarding breathlessness, is word found in one resource. It takes about 20 to 30 minutes to work, and this is where the timings come in. It isn't sort of you take it and within a few minutes you get that benefit. It takes a little bit of time. Again, we get questions about withdrawal and addiction. Probably the best thing is measure dose, and if you're finding you're needing more, do inform your prescriber. Only use at the dose prescribed, and caution with other medications. Those are particularly medications that can cause sedation or drowsiness. I don't think there's as much use of drowsiness or medications that cause sedation as there would have been maybe whenever I first qualified, but it's just this combination of using them all together can then start to slow the breathing. So the new one that we tend to see being used a wee bit more, now particularly probably from September 2024, that kind of time frame, is MST Continuous 5 milligram tablets, and this is your slow release morphine, and it's equivalent to probably somebody taking 4 to 6 doses of low dose morphine each day. Usually at about people are usually taking, people are usually taking about 1.25 to 2.5 mils. And MST continence tablets, there was a paper published that said that low dose morphine has the potential to treat chronic cough in people with idiopathic pulmonary fibrosis. And it basically said that this Pacify cough study is the first to show benefit of using low dose morphine to treat idiopathic pulmonary fibrosis related cough. And what they found was that they give slow release morphine tablets twice a day, 12 hours apart, or a placebo for 14 days. Cough frequency was measured with this VitaloJAK cough monitor. One of the challenges was trying to prove that actually somebody's cough had improved. And this monitor seems to help them be able to do that. It was a custom-built wearable digital device. And for all patients receiving morphine, the monitor recorded the daytime cough frequency, and they found that it reduced on average by 39.4% when compared with placebo. And for more than 40% of participants, cough frequency had reduced by 50% or more. Okay. So that was the MST 5 milligrams twice a day. And quite often then it can be titrated up. According to one of the talks I was at last year, they said up to maximum probably of 15 milligrams is what they would see. So it does show, it shows promise. It also, what they've said at the bottom of it is it shows the need for more, for more research. But that one of the benefits is that morphine isn't a new drug. We've been using it for a very, very long time. Into mucus and sputum, then it's the other thing that people tend to. So traditionally or stereotypically, the pulmonary fibrosis cough is a dry cough, but sometimes as the lungs become more inflamed and more irritated, they start to produce mucus, and this is or follow an infection. And you can quite often have people, and we will use quite often carbocysteine 375 milligram capsules. Everybody seems to refer to it as the big yellow capsule, okay, or the big yellow one. It's a mucolytic agent. So what it means is it doesn't actually reduce the amount of mucus that you have, but it thins it. It makes it less sticky, okay? And you'll generally see that you're going to have doses of 1 to 2 tablets 3 times a day, or 2 tablets in the morning and 2 tablets in the evening. Wouldn't use it if people have a history of, or if people have an active ulcer, and it's caution or to be careful if people have a history of ulcers. And then on to exacerbations. So the other big thing that we find people have is you can get a flare, a flare up, or you can say, right, what about, most of our evidence is, and most of what we know is based on our guidelines. So if you go to the GP and ask for an antibiotic, they're probably going to use the COPD guidelines. And this is just sort of the community ones that have put on. So first line is amoxicillin or doxycycline or clarithromycin, are the 3 that you're going to see. Okay. Amoxicillin, 500 milligrams 3 times a day. Sometimes in severe infections, they'll go up to 2 tablets 3 times a day. Doxycycline, 200 milligrams in the first day and then down to 100 milligrams. Just be careful. Doxycycline, if you're on pirfenidone, doxycycline increases your risk of photosensitivity. So during summer months, it is perfectly fine to be on both doxycycline and pirfenidone, but over that course of that period, you need to be, and for a wee while after, it's being particularly vigilant about skincare and sun. Okay. Clarithromycin is another very useful antibiotic for the lungs. 500 milligrams twice a day generally for 5 days, sometimes 7, and sometimes for some patients they will go a little bit longer. If there's no improvement after 2 to 3 days, quite often then it is important to go back. If it's no improvement after 2 to 3 days, or if it's worsening, and they then would say use an alternative first choice, and then they start to think about sputum samples, okay? And whether, so if you're producing sputum or mucus, then they'll take us, that's whenever they're starting to advise to send, to send a sample in. Sometimes we'll act faster if we know that people have had a history of recurrent infections and they've found that the antibiotic hasn't worked. Clarithromycin does interact. If we look it up, it interacts with nintedanib or OVF, so it does. What it does is it increases up the level of nintedanib. Technically, you can still keep going with both. You don't necessarily have to hold or stop nintedanib or OVF for that week. But because you're increasing up the levels, people have, then tend to feel more unwell. Clarithromycin is quite a tricky antibiotic to take anyway. It can cause a bit of tummy irritation anyway. And what I generally would advise is for the people to stop nintedanib for that week, and then as soon as they're finished, get straight back onto their nintedanib. But to take their clarithromycin, it is a very good antibiotic for helping with infections. So the other thing then that we see used a lot is steroids. So just out of interest, how many of you are on, if you don't have to say if you don't want, but how many of you would be on a regular, take a steroid like prednisolone every single day? Yeah, got some. Yeah.
Yep, I take 9
And
milligrams a day.
Hello,
hello,
hello, didn't get any of that on it, both broke up.
did it break up?
Yeah,
When did it break up? Is that Colin?
yes,
At the
When
start.
when
just at the
when did it
start,
break up? Just at the start of the steroids bit?
yes.
Perfect. Okay, so steroids is the other thing that we see used quite a bit. Steroids are also very useful. They're useful for dampening down inflammation. But over recent years, there's been increasing awareness about the long-term benefits and risks of use of steroids and when people receive repeated courses. The person who is going to know that you've received a repeated course is going to be yourself. And I know that one of the things we tend to hear quite a bit is, well, surely, you would know on the computer. As the healthcare system has changed, and I know we've moved to Epic and we can see more, in some ways we can see more things easily. And in other ways, with the private sector having increased, we don't always see things just as quickly. So it won't show up. If you've gone for increasingly, I think we're seeing people maybe attend private clinics and maybe getting an antibiotic or steroid, and systemic steroids are something that if you're on a long-term steroid, it is important not to stop it abruptly. And I also wanted to explain a thing called sick day rules to you for a wee minute. And then the other thing is, if you have had multiple repeated courses of steroids, then you need to start and think, and we need to start and think, right, I've had 3 courses of steroids in the last 6 months to a year. You need to be telling the person that's prescribing, because then we start to tip into that window where we're meant to go and down titrate more slowly. Okay. So usually then they would say that this is what it says word for word. The magnitude and speed of dose reduction in steroid withdrawal should be determined on a case-by-case basis, taking into things such as an underlying condition, how long the person's been on, the likelihood of relapse, and then things like gradual withdrawal of steroids should be considered in those who have received more than 40 milligrams of prednisolone daily for more than 1 week, being given as repeated doses, particularly in the evening. And generally, we would say take steroids in the morning because that mimics our natural steroid production. And then if they've received more than 3 weeks treatment, or if you've recently received repeated courses, or if you've taken a short course within a year, and then caution or being aware of stopping long-term therapy. So if you've been on steroids for a year and then you need another, you're off them for a month or 2 months and then you need a short course, then those are where we're thinking of things like withdrawing gradually. And it's because of this thing called adrenal crisis. Our bodies all naturally produce a little bit of steroid. And when we get steroids such as prednisolone, our body then says, right, you're doing the work for me, so I don't need to do it. This is where sick day rules come into. So if anybody is on a long-term steroid, then we have advice that came out probably in the last year or so about sick day rules. If you have a mild illness without fever, you don't need to change your long-term. And this is primarily for people who are on a long-term maintenance dose. So you'll see, maybe on 5 milligrams, 7 milligrams, 10 milligrams of prednisolone long-term. So if you have a mild illness without fever, usually they recommend no change in dose. If there's an illness with fever, so if your temperature's raised, your steroid dose needs to be increased for the duration of the illness. However, if you're already on prednisolone 15 milligrams or more, you don't need to take any additional. If you're vomiting or diarrhea, so if you vomit once, the recommendation is that you take an extra 5 milligrams of prednisolone. And if the vomiting persists and after you've taken an extra steroid dose and you aren't able to keep it down, then you should be presenting to, contacting urgent care usually. And then if you're extremely unwell, it's take an extra 20 milligrams of prednisolone. And at that point, you need to be seeking medical advice. Sick day rules then they also apply for things like minor dental procedures and major dental procedures. And those are things where you'd be saying to your dentist beforehand, I am on a steroid. What do I need to do with it? Generally, if it's a minor dental procedure, they'll say take 5 milligrams of prednisolone 1 hour before the procedure and take a double dose for 24 hours after, and then return to normal dose. This is then, so what we said, mild illness, no change, illness with fever, temperatures raised, your steroid needs to be increased unless you're, and then vomit or diarrhea. This is quite well laid out. So prednisolone 3 to 10 milligrams, unwell with fever 5 milligrams twice a day, and then prednisolone 10 milligrams per more. They're saying split the dose to twice daily, so take 5 in the morning and 5 in the evening. So does that make sense, or has anybody heard of those, or are you all up to speed with steroids and sick day rules? Uh-huh.
Jerry here.
Hello.
The steroids.
Uh-huh.
I have been on steroids constantly now for over 10 years.
Yeah.
Without a break.
Uh-huh.
Occasionally they would go up if I have a exacerbation or something, but
Yeah.
they've never come down as such. And is that usual for someone to be on them for that long time?
So whenever you say come down, as in you've never been off them,
Never been off
is
them,
that?
no.
But that is okay. Some people will be like that, and that is okay. So what I'm trying to say, and I suppose my take-home message is very much, if you're on a long-term steroid, it is important that it isn't stopped abruptly or suddenly, because your body will have got used to having that steroid. And if you're and when I say stopping abruptly, sometimes what happens is, there's times whenever our body won't absorb it that as well. That's where you're talking about what, that's gone up during infections and then back down again. And this, or vomiting and stuff. So whenever you vomit, you don't always absorb all the medication that you're supposed to. So this is the guidance that we're supposed to follow with, with steroids. And I think that over time we're becoming better at counseling and telling people about it. Whereas what we knew, and there was a big sort of alert came out a few years ago, and before that, people didn't have the same awareness. Okay.
Well, I'm Jerry's wife, Margot, and
Yeah.
he was on nintedanib for what, 20 years, and he was sick constantly and throwing up, and nobody ever told him to alter the steroids. Steroids were never mentioned.
Okay. And I think that's something where we're kind of, moving, more to knowing that we should, we should be saying, look, if you're being sick, you may, and you haven't been able to get your prednisolone, like, especially if it doesn't settle, then. And I think that's where we are now, where they were become, and we've got increased guidance. So there's a new thing called a steroid emergency card. Again, so before that, I don't think the information was out there that much, and that's why I included it today.
Yeah, no, it's interesting that you did.
Yeah.
He'd be talking. He rarely would ever speak to the consultant now, but I think it's been nearly a year. But he will be speaking to him in February. He has maintained that he had to stay on steroids just permanently. But recently Jerry had infections, and he wasn't told to increase the steroids either.
Okay. So this is probably where I would say we are it's one of the reasons why I brought it, is that I do think that this guidance is still getting embedded into day-to-day practice. Okay.
Yeah.
And these talks are primarily aimed at providing education to a large group of patients, and some will have received the information and some may not have. And that, to me, maybe would prompt you to go back and say, look, Is this the guidance we should be following? The pharmacist mentioned it in a talk that we heard recently. And how does that apply to me, and how should I be using it? Or do I need to be doing anything differently? Does that sound okay, Margot?
Yeah, it does. No, I'm glad you've brought that up because nobody has ever told Jerry anything about those rules, and probably, some people do fall through the net. He's been on it so long, so.
And I think
Also,
that is also one of the reasons why is that this came out a few years ago, and or as in fairly recently. I still feel that it is getting embedded into practice, okay? And that we're still getting better at it. And those are the people who are most likely to slip through the net, or the people who have been on it for quite some time. Steroids are excellent medications, and they are very, very useful, and we do use them very effectively. But I think that providing this is sort of building on what people know, or this next level of information. And when anything I've tried to pick to talk about today, I've tried to put the evidence with it, and how strong or weak the evidence is. So these steroid sick day rules are becoming, certainly, as I would say, more established into practice. Okay.
Okay. It's good to know that. So thank you for bringing it up.
I'm also on as well as being on the prednisolone, I'm also on mycophenolate.
Okay.
Well.
So it's the opposite. You stop it when you have an infection.
Well, nobody told him that either.
Okay, usually. So usually then we hold, or mycophenolate is usually because it's an immunosuppressant. And again, this is where you ask each time, if somebody is prescribing an antibiotic, if you're seeking assistance these should be reiterated whenever you talk to the person that is prescribing it. Okay. I am on these medications. I am on prednisolone. I am on an immunosuppressant. What do you feel I need to do in this situation, with these medications? Okay. And they may say, yeah.
No, it's good that you're pointing that out because his GP was actually in the house and put him on azithromycin, I think it was, for an infection. But and he would have a list of Jerry's medications, but he never mentioned either steroids or mycophenolate.
Yeah, and again, this is probably each GP does, would have a list of medications, and I'm going to follow on where I go with this talk will tie actually in with this, Margot. Okay. So, what I say to people, and I will get, I think I can nearly rush through to the end and say, look at this wee bit, I got it in. But I'm going to keep on going, and I will show you what I have at the end. Is that okay?
Yes, thank you.
But these are good questions, and these are good things that what I want to do is talk about and be advocating for you, knowing your medications and sort of being right. This is what's your advice, and this is what I've been told as well. Okay?
Yeah, thank you.
Inhalers then. So unfortunately, there's none licensed for idiopathic pulmonary fibrosis or for pulmonary fibrosis. Some patients are commenced before diagnosis for a presumed COPD, and some patients will have a mixture of both pulmonary fibrosis and COPD, and in those cases, it is appropriate to use an inhaler. Sometimes what I find is that if the inhaler was provided before the referral was even made into respiratory, okay, then it is always worth checking with your consultant if you get your diagnosis, because sometimes the reason you've been referred is they started the inhaler and the inhaler wasn't working. They did the chest x-ray. There was maybe something showed up where they did the breathing test and they thought they were restrictive. And for some patients, they will have been started on an inhaler and it won't be giving any benefit. And in those instances, it's always wise to have a discussion. If you're not finding or never found any benefit, do I still need to be taking this inhaler if it is pulmonary fibrosis and there isn't, an element of emphysema or COPD there? And it's a conversation I have with people quite a bit. When did it get started? Was it started by the consultant, or was it started before by the GP when you first presented and said, I'm coughing, I'm short of breath, And we look at those kind of things, and sometimes it's appropriate for us to discontinue it. Okay. And discontinuing it provides no difference to people's quality of day-to-day life, if that makes sense. So they don't notice a benefit or a worsening of symptoms. And for those people, it is appropriate for us to discontinue. Now, I would never, ever recommend discontinuing something without discussing it with your prescriber or with your consultant, but it is something there to think about, or something that I discuss with people. Okay. Then it mentions, if you look in the action for pulmonary fibrosis, it mentions this eosinophilic cough. You will sometimes see a steroid inhaler prescribed if the eosinophils are altered, and that can be appropriate. So when people say about inhalers, and sometimes I will have questions from other pharmacists or from other healthcare professionals, and they'll say, pulmonary fibrosis, do we need inhalers or do we not? And I kind of give this very gray answer of, well, sometimes, and what's the diagnosis and what do we know and when was it started? Okay. And they will sometimes be used in acute sort of infective episodes, so for a while. And that's because they're trying to manage that infection and the inflammation related to it, rather than the actual pulmonary fibrosis. Okay. The other thing then that we advocate for is vaccines. This is largely going on the Green Book. Flu, COVID-19, depending on age, I think now, pneumococcal vaccine, which doesn't tend to be repeated every year. It's usually a once-off. Sometimes it's repeated again. And then the newest one is RSV. So I am terrible at pronouncing. So it's respiratory I can't pronounce it. So whenever they say people, whenever people tell me that they can't pronounce medicines, us pharmacists or things, us pharmacists can't always either. Virus, it is one that is fairly new. RSV is when we first when COVID came, we started to test not just for COVID, but increasingly we're testing for other infections or other viruses. So we increasingly know if a person is admitted to hospital, do they actually test positive for flu? Do they test positive for COVID? And one of the other ones that you'll see is RSV. And it can, I think it's the age. It's determined rather than if you've received. So I think it's age 75. They're starting, they're to offer it, and some places are definitely quicker than others, and some people have had it and some people haven't. So it's another one that is recommended. Okay. And then there's other vaccines such as shingles, which are useful because generally it's about it's preventative medicine, or reducing the risk as such. Some people don't want for different reasons to take a vaccine, and I suppose my opinion is that it is okay. It is your choice, but it is recommended. Okay. Supplements. So one of the other questions we quite often get asked about is, what supplements can I take? And I've gone down sort of like evidence, what we have evidence for, and we don't have evidence to suggest that any supplement is going to help massively with pulmonary fibrosis. If there was a supplement, we'd hopefully be getting research on it and would be starting to try and use it. Vitamin D is recommended for the population, for everybody. A general if people ask what can I take, and I say, well, a general multivitamin that is not too high in anything, or not, that sort of mimics what our diet should incorporate, is not a bad idea. Okay. Things like cod liver oil, if you're on nintedanib, cod liver oil can make the blood thinner. Okay. And nintedanib, there is a theory that it increases blood bleeding risk, and blood thinners also can do that. So I would usually say avoid, or be very cautious if you're very keen to take it. And there are other herbal and homeopathic medications that do actually interact with your day-to-day medications. I was quite interested. I had a lady taking dandelion, I think dandelion root recently, and it did interact with with her antifibrotic with nintedanib, and St. John's wort is another one that tends to interact. So you can You can purchase something over the counter or in Holland and Barrett's and stuff, and it may well interact. Generally, I would ask people just to run it by me, and I'll try and we have a natural medicines compendium and a medicines information department, and they're pretty good at coming back to us to say, look, no, nothing flagged up, or they'll say something like, yeah, actually, we're a wee bit suspicious that there could be an interaction. It's probably best avoided. Okay. Now, on to managing your medication. So there's a no check ask campaign. And this is actually available online to download. And there's quite a good Word document that you can actually open up and then start to type in your own medications. Okay. Because what we know is, yes, Margot, you'd mentioned it. Surely the GP has a list of my medications. One of the challenges is the speed that they're trying to do the consultation at and catching everything. The person who will know what medication you're on or is generally yourself or the care, a family member that's filling a Medibox and stuff. So I am actually a big advocate of knowing yourself what medications you're on and why you're on them. I have people, I would get people up whenever they're starting antifibrotics, and I would go through all the medication that they're on and say, either bring your medication, bring me a list, and we'll take a look and see. And some people will be completely knowing every single tablet. Some people won't know the names, but they'll know exactly what they're for. And others will just, they just won't know. And or their family won't know, or they just know a little bit. And that can make it really, really difficult for us to tie in what is happening. When we get a list of medication, what we get is a list that has been recently prescribed. Okay. It doesn't tell us on that list what was stopped 3 weeks beforehand. Okay. So you could have something there like, a blood pressure medication. And if it was prescribed a month ago, it'll show up for about 6 months on your records, okay, from the GP. And we don't have access to see exactly what every consultation. So we can't see that it says patient Mr. So-and-so reviewed with GP surgery is prescribed such and such a blood pressure medication. Blood pressure was running low, so we've advised him to discontinue it. We won't see that, okay? The person that'll see it is actually yourself, and that's, we rely on family and and the patient themselves saying, actually, I was on that, but it got stopped about a month ago, and I'm not on it anymore. Okay. Epic has massively increased from a hospital perspective our awareness, but it doesn't translate over. So it has to be anything that's prescribed in GP land has to be manually inputted into Epic. The two systems don't really talk to each other. Okay. And so you have to nearly check, you always have to, as a pharmacist, I have to check both systems to know what a patient is definitely on. And I have to talk to the patient or a family member. And then I can sort of go, right, I know what you're taking I know what you're taking now. It sort of takes all those three sources to put together the puzzle of what a patient is taking. Okay. And that includes herbal, homeopathic, all those, sort of things as well that won't show up in your medical records. This is your managing. This is the other side of it. So you're managing your medicines that's one side of the wee leaflet, and then this is the other side. And as I said, there is like a Word document that you can open up. It's at no check ask, and even if you just Google it or SPPG no check ask, this comes up and you can type it in. So it's quite a good name of the medication, strength, how much do I take? I take it once in the morning. Do I take it every day? Why I take it, and any wee notes that you have. And you write down the date that you started it. So it does a lot of, some people will type them up and they'll open up a Word document and they'll do it all themselves. but other people, and other people might have a printout from the GP. This is a really good thing to do. Okay, it says things like not taking it anymore, put a line through it. This is the other thing, managing your medicines. I kind of think that I'm going to be talking today to people who are already probably managing their medicines very effectively, because so taking the time to come and listen to me today. There's different systems in place. These are all just from, all of these are purchasable from Amazon. Increasingly, we're finding that chemists are charging quite significant amounts for blister packs. And it's become, and a blister pack is something that people will ask us about. And it has its benefits in certain situations, and it also has its disadvantages, okay? It does certainly, I find that much fewer people will know what they're taking once they go onto a blister pack. They nearly, they'll just go, it's there, I pop it out and I take it. Whereas a self-filled Medibox, people sit down, they line their tablets up, they fill it up, or a family member does it once a week, and somebody then very much knows exactly what they're taking. If you're on twice a day, there's some that are morning and night only, and then you get others that you can sort of slot out where there's a Sunday and it's got your four different slots: morning, lunchtime, tea time, and bedtime. I had one person, and they were quite young, and they were trying to go to work and stuff, and they found this pretty thing that they could slip in their handbag. It's slipping, that they found was much, sort of found that it was more discreet or more friendly to use. And then timing, a lot of medications will say, like, our antifibrotics tend to all be recommended with food. And this is, I put the picture of the breakfast. It's a significant, eating them with a fairly significant manageable meal. I had one person ask me once if five Jaffa cakes was enough.
5 Jaffa cakes was enough.
5 Jaffa cakes. And I was like, not really sure 5 Jaffa cakes is what I mean whenever I say eat it with food, but alarms are very useful. Mobile phone alarms, things like that. I also had one person, and they said that they timed it with, as soon as they never missed their medication, because as soon as they were finished watching their soaps, they went and took their tablets. So whatever strategy works for you. Okay. The future. So I thought I would put this in. Future, we're all hopeful for new antifibrotic medications and new treatments for the symptoms. Okay. So FDA has approved for idiopathic pulmonary fibrosis, this Jascayd is the brand name, or nerandomilast. So this is what is hopefully coming our way very, very soon. Okay. Efficacy has been evaluated, and basically what it showed was that nerandomilast was, let's see, maximum amount of air. Individuals taking Jascayd or nerandomilast had a significantly smaller decline in FVC, so their breathing tests, when compared with placebo-treated patients. And the recommended dosage for it is, it's an oral tablet, and it's usually 18 milligrams twice a day, about 12 hours apart. Seems to still have problems with diarrhea and tummy trouble, unfortunately. And the dosage can be reduced to 9 milligrams twice a day, except in patients. So in the trials, they did use it along with antifibrotics, both nintedanib and pirfenidone, but there is an interaction between it and pirfenidone, which means that it doesn't work just as well. So they can't use the dose reduction with pirfenidone. And it is going to be interesting how the advice goes on how we should be, we would be using it, and what gets approved and what NICE tell us that we're supposed to do. But it is hope, I feel. Okay. So with that all in mind, then trials are also the future. there's a number of trials that, and I was speaking to Nazia Chowdhury just for an update on what is happening trial-wise. Coral trial isn't recruiting, but it's had promising results for cough with a medication called nalbuphine that has progressed to phase 3. So usually you hear phase 1, phase 2, phase 3, so the further up the phases, the more likely it is to be on, on the market. TPAL trial, we've had patients on, it's looking at lansoprazole in idiopathic pulmonary fibrosis. And then Whistle ENB 101 is a phase 2 trial. It's for idiopathic pulmonary fibrosis. And what they're trying to do is repurpose a medication. So it's a medication that's used for cancer, and they're hopeful that it might actually be able to be used for pulmonary fibrosis. Okay. Then there's a Conquest phase 2b trial. So amlitelimab and phosphodiesterase inhibitor with a name called BI. So before tablets get their own proper name, they tend to get this sort of code name. It's currently BI 1015550. So I don't know what they'll come up with to call it if it gets any further. There's a MIST phase 2b trial, and it's looking at nebulized pirfenidone, more so in PF-ILD than in idiopathic pulmonary fibrosis. And then there's a Fibronir SARD phase 3. It's looking at nerandomilast in patients with rheumatoid arthritis, sclerosis, Sjogren's, myositis. And then we've BREEZE, which is a breathlessness management training. So it isn't drug, it isn't medication. And that's also important, is looking at the other things that are an option. So there is a lot of good information on cough management, breathlessness management, those kind of things. And they should never be put to aside. They can actually give real benefit and significant benefit. So this is a really good trial that doesn't involve a medication. Then there's Sapphire phase 2. So Zampilimab, which is an IV infusion every 3 weeks. And then LYT 100 is dupirfenidone. So it's a new type of pirfenidone with potentially better tolerability. And I think patients shouldn't have ever had pirfenidone. And then there's a sarcoid study. It's an IV infusion on PRED. The patient have to be on both prednisolone more than 7.5 and methotrexate. So that is, I think, everything that I wanted to go through with you. Thank you very much for your time. And does anyone have any questions?
On the Oromorph, I'm on the MST slow release twice a day. And I'm also on the Oromorph, supposed to be 2.5 4 times a day. If I want it. But I don't think it doesn't seem to be doing me any good. I take it in the morning before I get out of bed. And then I take it before I get into bed at night time. But I just question whether it's been any benefit to me or not.
I think that's quite a that is quite a difficult thing to assess, and this is where these trials come into play. So for about 50% of people, they actually, it was helping, particularly with cough. The challenge with it is that whenever you drop it down or withdraw it, and then if it's how do you know it's working? And unfortunately, it's if you take it away, which I wouldn't necessarily recommend doing, you then find that things worsen. Okay, so it can be ticking away in the background quite effectively.
Right, because
especially the MST in the morning and the MST at night, it can be ticking away in the background quite effectively. And
I don't have a cough or such.
It's the breathlessness you use it for more.
Right, yeah, okay.
Isn't it?
That is.
So, yeah. So we use it for both. And that is just it. Sometimes whenever people start it and they're on it for a short while, they tend to find that, maybe it didn't make much difference, and then they stop it again and they go, actually, that was working and, helping. because the challenge is none of these things take away the cough completely or the breathlessness completely. You know, they move it down maybe a notch, but they don't remove it completely.
I would find with whether it's the slow release and a combination of it and the actual liquid, that probably mid-morning I would maybe be feeling a wee bit drowsy.
Sleepy, yeah. And that's and it's weighing that up, you know, but I think that sometimes it's and we know it can, you know, we know it can make people feel a little bit drowsy, but it's balancing it up that you're not, you know, complete, you know, very sedated or having a problem. But it is useful. So I wouldn't recommend stopping it without either a chat with me off, you know, off this, or is that okay?
Yeah, that's fine. Yes, thank you very much.
I'm on the whistle test.
And how's that going for you?
It's going great. I'm just after being up at the centre there. And I'm on the tablet, the proper one, like, because
Okay.
I've had the side effects of muscle cramps, and I'm getting an awful salty taste in my mouth too. And that all came about around the same time.
Okay.
You know,
You're fairly confident that you're on the actual medication.
Yeah, I think everybody is.
Okay.
So, well, I can't say what's happening like yet, but it's looking good.
Good. Well, I think it's great that you're, you know, it's great that you're participating, and I hope it goes well for you.
You have to. They're giving me stuff too to help with the salty taste in the mouth and that.
Okay.
And I had stuff there for the muscle cramps anyway, and I increased it with my own doctor, and it's helped.
Good.
So they've taken note of that.
Good.
So,
no, that's really good, and it's the with that then hopefully we'll have more information, and also I suppose what we know is that usually whenever you're on trials, some people say, well, and monitored a bit more closely, you can sometimes have a bit of running about to do, extra appointments, and some people see that as a plus.
I'm not doing anything anyway.
Okay. Anybody else any questions?
Yes.
And I was, while you were talking about the supplements, taking supplements or any vitamins, well, you said don't take cod liver oil if you're on OPEB. What about omega-3, or is it?
No, it's a wee bit.
Sorry?
It's the fish oils. Some of them do and some of them don't. If you give me the brand or anything, I can look. And sometimes it's to do with whether they think it's actually, quite interestingly, whether they think is it vegan, whether it's a vegan. So you'll not get a fish oil but an omega-3 that is a vegan prep can interact differently compared to a non. So an actual sort of meat or fish source. So if you want, give me a wee, Abraham, if there's something you're keen, then
that it's not clear. Can we take it or not?
Am I clear? Not pardon?
Or is it certain type of omega oil?
Sometimes certain types can can cause more of a problem. But if it's something that you're interested in, if you give me, I know I would be talking, give me a wee call and I'll have a conversation with you or check things out. I think it's always best to check these things. Okay.
Right. Okay. Thank you very
much. Hello, Anne. Could I just ask a question? And it's about the Tinidab. You know the way it's supposed to be taken 12 hours apart. How essential is that?
So Mariam touched on this last time, and I would be of the same sense. I tell people 10 to 12 hours apart.
Right.
Okay.
No, it's just that
So,
it's just that someone asked a question online one day, on the Zoom call and things like that, or they sent a message on our Zoom thing. I was on a trial with up in Derry, and it did cause a problem that I couldn't fit into that scheme because I couldn't take the Tinadab before they started whatever tests they wanted. And I asked one of the nurses and probably actually one of the consultants about this 12-hour thing, and they said there is an overlap, and it's not a strict
all
thing.
over the product literature.
Yeah.
Okay. So if you read the patient information leaflet, it says 12 hours apart.
No,
Mariam,
since I've went on oxygen, I'm finding that I'm not eating as much, and taking food's causing a problem.
Yeah.
And it's just that I can't. I'm down to probably about an hour less. You know what I mean? That if I have my breakfast at 8, the other thing will probably be before 7 o'clock at night. You know that.
That's, to be fair, if you're in an 8, if I would tell people if they're in an 8 to 6 sort of window, they're about spot on, breakfast at 8 a.m. and taking their tea and nintedanib at 6 p.m. is perfectly, is perfectly fine.
Yeah. Okay, then that answers my problem.
Does that answer that?
Thanks very much.
Yeah. Okay. Anybody else, any questions, or are we ready to finish up? I think I've noticed I've gone over time, so I've talked for an hour and 10 minutes, so I've done quite well.
You carry on, Anne, as long as you wish.
Tom, anything you wanted to ask?
No, I just wanted to make a comment, and I find it extremely interesting, particularly whenever at the later session when you were talking about a lot of the trials that are going on. I mean, it is encouraging. We do talk about it within the support group, and we are hopeful that nerandomilast will be something that NICE will approve fairly quickly. I am aware of people who have been taking it side by side with another antifibrotic as well during the trials and found very little side effects during the trial period. So I'm quite hopeful that it comes as another tool in the box, if you will, for our healthcare professionals here in the UK going forward. And I am hopeful that it comes out this year because that, along with being able to inhale pirfenidone, etc., going forward, that's going to bring a lot of hope to a lot of patients. Just if it's just quality of life alone, at least things are moving in the right direction. So, and I'm aware of a lot of the trials you put on, and it's nice to let people know what's happening. And I appreciate Eric, who's usually in his car during our Zoom, talking to us, giving us an update on what's going on with his trial, because quite a few of those trials, I think people are a bit cautious about doing trials, but I think it's also always worthwhile asking others. And also, the trial can also benefit the patient, particularly if the medication's helping you and you're kept on it. And you're not left out of pocket with a lot of the trials, because you're either going to be taxied there and back again, or your expenses are going to be paid. So I would always encourage people and anyone on the group who wanted to take part in trials just need to send me a personal message, and I'll get in touch with usually Dr. Nazia Chowdhury, who would facilitate a lot of the trials and pass their details on, and they would be contacted to see if they were suitable for any of those particular trials. So if anyone wants to have a go at a trial, just let us know.
Definitely. I fully agree, and that's why I put it in. I think that one of the things we find is that, and as I went through and put together the talk for today, some of it is, always going to be information that what you know already.
Yeah.
But I do definitely think that one of the things that struck me was how little we have that is licensed and approved for pulmonary fibrosis. And that is why I kind of went, what's the future and what's the hope with regard to medication, because that is primarily going to be our answer in the future, you know.
And it's repurposing as well, there's repurposing some of the drugs that are already on the market to help patients as well. I know that there's talk about some of the diabetes drugs as well being available. There's a remap ILD going on at the moment, and they're looking at repurposing some of the drugs as well, and that's being looked at worldwide. So it's nice to know that we seem to have gone from a long time, 2013, 14, without very little happening. But in the last 2 to 3 years, I've noticed there's a bit more of an uptake and a lot more interest in what's going on with pulmonary fibrosis. So I'm quite hopeful for patients that there is something that's going to slow it down significantly. And I'd like to think that that's going to come to us within the next 5 years anyway.
And I think that is definitely how I would, feel about it. And I think it has probably stood me in good stead, having moved from a cancer background to pulmonary fibrosis, because actually where we're probably getting some of these medications too, if you look, or we're using it. And I think that also you see leaps every once in a while. It feels like we're treading water and we're not seeing much, and then every once in a while you see a really good leap in treatments, and you see better outcomes for people, and that's what we want, because it is very serious and very, and that's me speaking to you who are having to live it, and I'm seeing it on the other side, but not having to live with the symptoms and side effects and so on and so forth. But I do appreciate how much of an impact they have, and how serious pulmonary fibrosis is.
Mm-hmm. No, I really do appreciate you coming on, Anne, and I think you've complimented what Miriam went through earlier on, and it was kind of seamless. So and what we do with with all of these talks, we have a YouTube channel, so we download them onto YouTube. They then go onto our website, and after this talk today, what will happen is that they'll be put out on our WhatsApp groups as well to the patients, as well as onto our website. So they're held, for as long as people want to see it, they can go and look at it, and they'll also be available on our WhatsApp groups as well, so they can see it straight away. So I really do appreciate that, because it gives us a library of information that people being newly diagnosed, or people who are wondering what they can do about diet or what's happening with antifibrotic drugs or whatever, they can go on and have a look it up, and there's something there in the library, and it's from somebody who knows what they're talking about. You're not going and looking on the World Wide Web, that you can get quite confused about what's happening. And also, when it's UK-based treatment we're talking about, and particularly in Northern Ireland treatment. So it's always good to have it, and have it up to date as well. So thanks very much, Anne, for that. I really do appreciate it. And thanks very much for your time.
Thank you very much. No problem at all. Thank you.
Thank you. Thanks, Anne.
Thank you. Thank you.
Bye-bye.
Bye. Bye now. Bye.
Bye.